evening. If I could ask everybody to take a seat, I think we'll go ahead and get started this evening. Well, welcome everyone. My name is ALLAN with American Public Square, and I'm delighted to see you all here this evening. I'd like to thank our sponsors for tonight, the Healthcare Foundation of Greater Kansas City and Swope Health Services. On May 22nd, we'll have our final program of the season, Home Sweet Home, Aging in Place. There's more information available on page 3 of your playbill, or you can take a look at AmericanPublicSquare.org. You can also keep informed about American Public Square events by signing up for our mobile texting, and directions on how to do this are also in your playbill on page 6. If you're a member of American Public Square, would you please stand up? Ah, look at that. Let's give them a hand. If you're not a member of American Public Square, on the back of your playbill is a list of different membership levels. And if you'd like to become a member tonight, you can see me outside after the event. We have a table in the lobby, and I'd be happy to talk with you. If you'll notice on your table, there's a survey that looks a lot like this. If you'll take time to fill out the survey prior to leaving tonight, you can either hand it in as you leave or leave it on your table, and we'll collect them after the program. You also received on your tables question and fact sheets. They look like this. One side is a fact check, the other side is a question. If you have a question or a fact check, please write it on the sheet, hold it up, and a volunteer will come around to collect it. It will be given to our roving reporter tonight or to the fact checkers. Where's Nick? I see him, there he is. Nick Haynes of KCPT is tonight's roving reporter. Nick, all right, Nick. So Nick will be asking the questions that you submit, or he may come around and ask you to state the question on your own. Scott Curtis, who's over here, he's waving. Hello, Scott. Scott is a UMKC librarian, and he'll be doing our fact-checking for tonight. Several of the members of our audience have civility bells on their tables. Would somebody ring one if you have it? There it is. So these will be rung if the tone of the conversation tonight becomes less than civil, so panelists be forewarned. And we also ask that you not clap during tonight's discussion. It's now my pleasure to introduce Dr. Bridget Mccandless, President and CEO of the Healthcare Foundation of Greater Kansas City. Bridget.
Good evening. It's wonderful to see so many faces interested in this advancement of both civil and civic conversation. What we know is that the issues that face America are both complex and nuanced, and it is our important obligation to find ways to understand these things better so that we can make better decisions for the many people that live here. The Healthcare Foundation has been sponsoring some of these and have been delighted to be partners with American Public Square. I will tell you, when we started talking about public health, they were thinking about titles, and I, of course, went right for the end of times, and I said, let's go with life without public health. And they said, well, maybe we could back it off a little bit. But you know, public health is one of those under-recognized gifts that you don't even think about, like stoplights, until they aren't there. And as Flint, Michigan has seen, a world with a cracked public health system is not as good as the one that we expect. As people begin to really think about population health and about the well-being of all people, not in a sickness model, but in a wellness model, population health is going to rely on a strong public health infrastructure. And because of that, it's one of those that I think people need to have a better functioning understanding of what public health does and what we would expect if public health wasn't there. So I thank you very much for spending your evening with us, and I turn it over to Ambassador KATZ and our fine panel. Thank you.
No.
how about this? Can you hear me now? While they're working on that, I'll use this. And Nick, do you have one, Nick?
Going on? Yes,
Okay,
it is
fine.
going on right now, bright-eyed and bushy-tailed,
Okay, well,
at the end of the room here.
Okay, well, hopefully these others will work as well, and we'll find out in a minute. But I want to thank Bridget, and I want to welcome you all to tonight's program. This is the third program that American Public Square has presented this season with the sponsorship of the Healthcare Foundation of Greater Kansas City. And we are very grateful for not only their support in helping us put these programs on, but in the knowledge and the framework that they've given us to advance conversations about important issues. We opened our seasons in September by looking at the opioid crisis, which obviously is something that's very much in the news. We followed that with the dinner in February on the social determinants of health. And tonight we conclude with, as Bridget points out, we changed the title slightly to, instead of the end of time, we decided to make it Eat, Drink, and Be Healthy, Public Health Services. It's my pleasure now to introduce our panel. We feel very fortunate to have them. We have, to my far left, is Lee Norman, is the Senior Vice President and Chief Medical Officer of the University of Kansas Health System. He is also Lieutenant Colonel in the Kansas Army National Guard, and Lee is the State Surgeon of Kansas, as well as a mountain climber. Next to him is Sarah Martin Anderson, who has a PhD and is the Manager of Community Engagement Policy and Accountability at the Kansas City, Missouri Health Department. Sarah is an adjunct instructor at UMKC's Block School of Management and is active in philanthropic and political organizations around the region and nationally. And to my immediate left is Dr. Randall Williams, who's the Director of the Missouri Department of Health and Senior Services. As a practicing obstetrician, he has delivered 2,000 babies. He is an avid runner and has run marathons in Boston, New York, Paris, Athens, Florence, and Jerusalem, which means that since I run in Chicago, that means we run different places. Anyway, please welcome. So to follow up on what Bridget said in talking about the topic tonight, let me sort of start with you, Randall, in terms of how do you define public health services?
Great. If I just may add quickly just how much I appreciate the opportunity to be here. An old country doctor told me the summer before I started medical school that I'd always be judged on three things: my availability, my affability, and my ability, but in that order. And I thought, no, wait a minute, if if you have skills and you're nice, that should be enough. And I've really found that's not true, that you have to be available. So tonight is a great example of giving me an opportunity to be available to you. The only thing I negotiated with the governor when I came here was I would go to all 115 counties in the first year, and I've been to 85 in the first 3 months. And I do that to listen. So much of what I'll be sharing with you tonight is based on observations as I've traveled around Missouri. But Ambassador, to answer your question, I always look at public health. I have a very broad definition, as Bridget and Rex would tell you, which is really the health, safety, and well-being of the population, of the community. Now, it's interesting. I think if you look at the traditional core values of public health, assurance and assessment and policy, we certainly do that. But I can't applaud you enough for engaging this debate tonight, because I do think public health is very much at a crossroads. If it is those three core functions, then yesterday I was in a county, 4 employees that in Missouri that has a public health department and probably a budget of $300,000. And today I'm in Kansas City that I would argue may have the premier public health department in the country. And I'm not just saying that because I'm here in Kansas City. It's just true. I come from North Carolina, which is a thought leader. We have the #2 school of public health in the country, private or public. And we have nothing that looks like what you have here in Kansas City. So the question before us tonight is if we are supposed to be about the health, safety, and well-being of the community, and if we are supposed to be about assessment and assurance and policy change, what are we going to look like the one I was at yesterday, or are we going to look like the one in Kansas City?
Okay, so Sarah, as someone who works in what you just heard is the best public,
Yes.
health service in the country,
Yes.
health department in the country. tell us about your perception here of what that means in terms of public health services, and talk a little about the support you get or don't get from the state of Missouri.
Thank you, Ambassador. I want to agree with everything Randall just said about the Kansas City Health Department. I also want to point out and thank my students who are here. They're over here, they're waving. Those are my health and social equity students, MPA from the Block School, and we have a final exam period at 8 o'clock today. So when you see all of us run out, I just want you to know that that's why I'm running, not because I don't want to engage anybody. And my colleague Joey Leitner is up here. He's got my business card, so he's in charge. So if you want to talk about any of this later. Kansas City is very special. It's a very special health department, and one of the reasons it's very special is that I think they have a real innate understanding of the changing face of public health. I've always seen the public health field as one of social justice and equity, and I believe its roots are in kind of sounding the alarm. So when we know what is causing something, it's our job to make sure as public health workers that we are doing everything we can to get to that root cause. And if that root cause is a water pump, that's one thing, right? That's like the birth of our field. But if that root cause is racism, classism, sexism, well, then we have some other issues we need to deal with, and that's very difficult in these smaller health departments. But it's just as difficult in a very large health department because that is, it's a transition, and it's something that we're dealing with. Now, we talk about support from the state. We get here from the state general fund 28 cents per person, per capita. The majority of our funding comes from local funds. So we tax ourselves. So we have a very robust property tax in Kansas City that funds not only public health, but health services, so safety net health services to the tune of $30-something million. And then you add EMS on top of that, the fire department. And you have what is, to me, one of the most impressive things about Kansas City is how much people overwhelmingly, the voters overwhelmingly tax themselves for public health services. So I think that we have a lot of support there. We are a grant getter. We are almost, Dr. Archer will likely correct me if I'm wrong, and that's fine, he can do that. A third grant funded, and that's just direct funding, right? So if there's two kinds of support from the state, there's going to be general fund and there's going to be pass through. So if the state does not have the capability to pull down federal funds, if they're not competitive, then that means that we also lose out. So compared to other large cities like us, we're looking at underfunding of some $6 million because the average across the country in those big cities is $14 per person. So it's 28 cents versus $14 is a real struggle for us because what we're doing now is relying a third on very unsustainable funds. We don't know administration to administration what those federal grants are going to look like, so it's very, very hard to govern and to think long term from a public health perspective if we're not sure where the money is coming from. So.
And it's 28 cents a person. What was it, say, 20 years ago, more or less?
I'm guessing closer to what the average is of the big cities. I think it's something like $15, maybe $17. In my head, I'm imagining Dr. Archer taking out a quarter and 2 pennies, and then he also took out some cash, and I don't remember how much that was. So you'll have to correct me if I'm wrong. It's a real significant difference, and the city has made that up by taxing themselves, by property taxing themselves.
So Lee, Kansas is different than Missouri in a number of ways, and sometimes it's the same. And basically, in your position there with a public health system over there in a large hospital, a medical school complex. Would your definition of public health jive with this, and also the identification of what people need to focus on?
I have not felt any need to be uncivil at this point. I agree entirely so far with my two colleagues up here. Agree.
We're happy to hear that.
Yeah. And let the record reflect, I live on the Missouri side, 700 feet into Missouri, and I work 700 feet into the Kansas side. So I bring a bi-state opinion of this. But this is my 26th year of being a chief medical officer. KU is the smallest hospital I've done that in. I was many years out at Swedish Health System in Seattle, Washington. before seeing the light and moving back to the Midwest, to my roots. But I have to tell you that I think hospitals, one, are very, very difficult to run. And let me give you a snapshot of what a busy hospital is like ours. We'll have 700 patients in beds at midnight tonight. That means we discharged 160 patients today. We admitted 160 patients today. And that doesn't include the thousands of patients in the 100 different clinic settings that we see. So, in order to keep Nick happy. And what I see is just an awful allocation of resources, or a lack of allocation of resources to the patients that finally make it to us. Let me give you some examples. Today, every Tuesday morning at 8 o'clock till 9:30 in the morning, I go through what's called our long length of stay patient list. Today was 72 patients in length, so 10% of our inpatients. These are patients that, for a variety of reasons, are stuck. They might only have been there for 5 days, but it's apparent they're going to have nowhere to go, maybe very end-stage disease. Some of them have been there 300 days. So I went through today, and we have 80 case managers and social workers to help us navigate these folks. And 10% of them were in this country illegally, will never have health insurance, and don't have any money. They're going to be really tough when it comes to like dialysis, for example. 10 of those patients were Medicaid pending. And to Missouri's credit, Medicaid didn't expand in either Missouri or in Kansas, but at least when a patient comes in and qualifies for Medicaid, at least the state of Missouri turns it around pretty quickly and gets them qualified. In Kansas, they'll be there 100 days, 150 days, sitting on the application as, I think, a way to minimize the expenditures in the state of Kansas. So 10, 15 patients will be there Medicaid pending. The day that Medicaid coverage occurs, then they can leave the next day to a skilled nursing facility, a brain injury rehab hospital, et cetera. 10% of patients are new amputees. Most of those are people that didn't have diabetes treated. I could go down with each one of those, but the bottom line is they're all end stages of things that, one, could have been recognized early, and two, we see it at the very end stage. We saw a man today, for example, that came in with a perforated large bowel, and it was from a colon cancer, and he'd obviously had never gone through colon cancer screening, or the first harbinger of his newly diagnosed colon cancer would not have been a perforated large bowel, and he'll have a tough go, needless to say. I'm a family doctor. I've been a family physician for 35 years, and forever we try to focus on the things that I think that we can agree on that public health needs to do really well. And some of those are, and number one is immunizations, and number two is colon cancer screening. We have a longer list than just that, but those are the ones that we said we want nobody to have not had immunizations offered to them in a timely fashion. And the anti-vaccination movement just baffles me, I must say. When was the last time you ever went to a picnic and have somebody say, oh, that was the year that baby Helen died of diphtheria and Charlie got polio? It just doesn't happen anymore, and it's on the strength of immunizations. So I agree with my colleagues, and I think it's really a matter of prioritization, and investing in the end of life and late care in hospitals is an awful allocation of resources.
So to follow up what you just said, and the other panelists comment, so has the public health system failed these people? In other words, you talk about people who are in need of what you call basic types of screening, and so the fact that they show up very late or in the stage, which, and we all know the economics, we don't even talk about the economics. The question is as a system, are we failing these people?
Well, I think I have two answers to that. One is I hold public health professionals in the highest of regard, but we don't have enough resources being channeled into what I think to do a credible job of public health. And I don't lay that at the feet of the clinicians and the programs that are in place. I think everybody's working as hard as they can. And I have been in my entire career, I was a social worker before I went to medical school. And I remember thinking back in the day, we are going to have problems funding enough mental health. And I think that is one of the primary areas of public health services and community health. And again, I don't lay that at the feet of the clinicians and the practitioners and the community service workers. It's just that there is a monumental amount of work for them to do. And with the dumping out of the state hospitals and the poor funding going to public health and community mental health, we are just not keeping up.
Okay, so Randall, is the state of Missouri or your state of North Carolina where you work, are they failing these people by not giving enough resources to the public health system?
Well, where we're going, and as you know, Missouri is 50th in public health funding. That's a known fact. And so where we are trying to transition, as we anticipate Medicaid will come back to Missouri in a capitated block grant. The governor and I were supposed to have a conference call with Tom Price on Friday, but he had a little bit of a busier day on Friday after Thursday's vote, so we postponed that. But we think there is a tremendous amount of money in healthcare in the United States. We spend about 18%, 19% of our GNP on healthcare. So unlike other countries I work in, Iraq, Afghanistan, and Libya, there is plenty of money in healthcare in the United States. And so then you look at our outcomes and go, well, how can that be that we have all this money we spend and yet our outcomes aren't what any of us would hope they would be? And if you look all around the world, the answer to that is prevention. We have a system now in the United States that does exactly what it is designed to do, which it rewards treatment. I was an obstetrician for 30 years. The more hysterectomies I did, the more money I got paid. And you can multiply that by hysteroscopies, endometrial biopsies. I got reimbursed on procedures. And that is how healthcare works in the United States. It has collateral issues. We have 105 out of 115 counties in Missouri that don't have enough physicians. We have 60% of all the doctors in Missouri practice in 3 counties out of 115. And so I'm broadening the scope purposely because the governor and I feel that this is a continuum, that when you talk about public health and population health and community health and prevention, you have to integrate that in to health care, period. If you look at all the facilities, none of the hospital systems now, and that's what they are, they're not hospitals, they all own doctors. I looked at the numbers the other day, I think 75% of all the family doctors and internists in St. Louis are owned by somebody. In North Carolina, 75% of all doctors are owned by one of our 4 big systems. So they're not hospitals anymore, they're healthcare systems, and they don't say healthcare treatment systems, they say healthcare systems, which implies prevention. So where we're planning to head, to answer your question, is we think the future for public health is to integrate it like we did in North Carolina into the healthcare continuum and shift resources from treatment and shift them into prevention. Because the average Missourian now lives 30 extra years than they did 100 years ago. And we celebrate that. My mom is 88 and works full time, basically. You can call her and fact check that. She'll debate that, but she goes to the office every day. But she basically works still full time. Actually, do call her. I'm curious what she would say about that. I'll tell you a funny aside real quickly. I go around and give lots of talks, and I always work that in there. And she'll inevitably call me 2 days later and say, "Did you go tell those people that I'm 88 and work full time?" And I said, "Well, Mom, it did come up because it kind of illustrates a point." She goes, "It sounds like you're bragging, and I don't like you bragging about me." And I go, "Okay, Mom." So anyway, our answer to this is that we think the future, and I've been very transparent about this with every healthcare system. I've met with all of them here in Missouri, I think, is that we think the future of public health is to integrate it into the healthcare systems and shift more money from treatment to prevention.
Okay, Sarah, jump in on this one.
Yes. The social safety net failed these people. We have failed as government. So maybe not me, maybe not any of us sitting here, but sometime long ago, a man in Kansas City decided that if you were black, you could not own homes on one side of a street. And then we named a fountain after him, and we named a street after him, and we made a lot of mistakes along the way. And I think putting it at the feet of public health, and this conversation so far has been dominated by clinical care, even prevention, clinical prevention, that one thing we have to deal with now is the decentralization of public health. And public health needs to be integrated into city planning. It needs to be integrated into economic development. So why are folks not accessing care? They might make too much money for Medicaid, right? But it could go back to what happened to their grandmother. It could go back to what happened to their mother when they were in utero. And we talk about early childhood education is a public health issue, and economic mobility is a public health issue, and that is the crossroads we are at in public health, because those are the complicated underlying social forces that are creating, it's great we're living longer, we should be, but poor white women in the boot heel are living 6 months on average less than their mothers were, right? So it's not equally shared, and we all know that up here. We know there's a 13-year life expectancy difference. Many of us were in the panel on social determinants between one zip code and another. We know that the race is still a significant predictor even when you control for income, so it's not just about poverty. So we know these things, and if we fail to act on them over generations of policymaking, that's a choice we've made. And I think it's up to us as public sector to say, okay, we failed and we made a mistake, and what are we going to do about it now? It might mean giving up some territory. So there's often this tension between population health versus clinical health, but they're both so important, right? But what are we going to do to integrate across all departments in the city, across all sectors? That's the central challenge we face now, in public health, I think.
Go ahead.
Yeah, if I could just follow up to Sarah. I mean, again, I think in St. Louis we have contiguous zip codes. I was in one that's 30 years difference in the lifespan, which again, I was visiting an FQHC there. And again, that's poverty. We know that poverty and education are directly tied to longevity and health. And so we feel very strongly that, I tell people all the time, if you care about education, then you need to care about health care, because in the Missouri state budget, we're spending about 35 to 40% of our state budget on treatment, okay, for Medicaid. So if you're spending that much money and 19% of your GMP on treating people, on operating on them, on dialysis, on end-stage things like Lee was saying, then you're not going to have money for education. You're not going to have money for those social determinants. And it only makes sense that we as clinicians accept that, because I think we have a huge responsibility to be as efficient and save as much money as we can, like other countries that spend 12% of their GMP, so that we can then free up money that goes to education so that people will be healthier. It works very nicely if you approach it that way.
Okay, so I'm listening to what you're saying, all three of you are saying, and I noticed that Missouri and Kansas rank at or near the bottom for state funding for public health services. And we know that the clinicians and the medical professionals that we know, they all work hard, they're all dedicated people. Well, and I don't believe casting blame is particularly helpful. What I do think is important is talking about who's responsible for not doing the things that you all are talking about. I mean, what you're talking about is not something that no one in this room has ever heard before,
Right.
nor is it something I suspect something that none of you have ever said before. So the question is where does the responsibility lie, and how do we sort of move in the right direction?
Okay.
We all just talked.
Well, I look at what we collectively, public health and the provider community, should look at as a portfolio of things that we should be able to do and to offer, and to say, what are the things that really have value? I know, for example, that a lot of the care, most of the care we do in the hospital in the last 2 weeks of life are all for naught. And we can pretty well predict who is at the end of their life, and if it's a good, and I don't mean to sound callous, but if is is this aggressive care at the end of life, despite the fact that this is what the family want for the loved one that's in the intensive care, is that the best investment? My answer to that is no, it is not the best investment. And yet, it is, you could fund a county in the Boot Heel with 1 month's worth of that kind of care in a single intensive care unit, no question about it.
But again, what you're telling us is what most people who have paid attention to this debate know. Someone, somewhere along the line, decisions have to be made. Resources are finite, whether we think we should spend more or less on one thing or another. You've identified a fact, okay, an economic fact. Whose responsibility is it to stand up and sort of say, so therefore, folks, we're not going to spend this much in the last 2 weeks of life because we need to spend the money somewhere else?
Well, again, I've been incredibly transparent. As I've traveled around Missouri, we have clearly challenges. But the one thing we have is just tremendous human capital. We have some really bright people here in Missouri, and some of them are sitting in this room that I've met. And I work all over the world. So our pledge and commitment from the governor and me and others is that in this iteration of healthcare reform, it's the third one I have been through in my life as a clinician practicing for 30-something years, is that we want the thought leaders in Missouri to lead it. We want Charlie Shields and the people at Truman and the people at Kansas and the people in St. Louis at Barnes Jewish and Rex and Bridget and Bob Hughes. We want those people to help us design a system. The money is going to come from clinical care. Okay, so when you ask where's the money coming from, we're going to transition from clinical care, spending a lot on procedures. And you say, well, Randall, how are you going to make them do that? I'm not going to make them do that. They're going to do it on their own because we're going to shift into a model in which we don't reward more procedures. We actually reward those people who can figure out innovative ways to keep people from having procedures.
But wasn't that part of what was contemplated under the Affordable Care Act?
It didn't pan out. But what happened with the Affordable Care Act is that there was a huge premium put on access, that you just need to get more people access to the system. Okay?
And one other thing that I'd like to hear from the other two on the subject is that my recollection is under the Affordable Care Act, there was no copay for physicals. And the only reason I knew that was when I went for a physical and I went to do my copay and they said there isn't any. The theory being, again, prevention, presumably getting people in for physicals. But how,
But did the Affordable Care Act change the basic, the more procedures you do, the more money you get paid?
I don't believe it probably did. So the question is, Lee and Sarah, do you think we can get there? How do we get there?
I don't see this conversation as one on health care policy or building incentives in the healthcare system. I see this as trying to communicate that public health services are about changing the environments we live in so that the easiest choice is the best choice, right? So if we're thinking, did you get your physical? Well, I'm not as concerned about you as someone who may have zero access to physical activity, living in a crime-ridden neighborhood, chronically stressed, no job, no mobility, no quality schools. That is what I'm very, very concerned about. But so much of public health services are never mentioned, right? So environmental inspections, lead inspections, nurse home visiting. Forget the clinical care, though we love them, and that's what we need to be screening early, and then we need to track, where are your sexual partners? Did you come in and have a positive chlamydia test? Do you know that there are public health workers whose job are to track down your sexual partners? I mean, that is something we don't talk about when we're talking about public health, because if we're doing our job correctly, you'll never know we exist. And in kind of a data-driven budgeting world, it's very difficult to communicate the importance of public health, because you might never know. Unless there's an Ebola outbreak, you might never know we exist and do emergency preparedness. But the minute something happens, we're ready to go into action. And you go to your restaurants, we inspect all the childcare facilities, we inspect all the pools. So unless we get like bad press for closing a pool on Memorial Day weekend, it's really difficult to get the reward, like the kudos, like you didn't get diarrhea. Congratulations, like we're here for you, right? So unless something bad happens, we don't get a lot of that. And, you know, so much of the national conversation is dominated by healthcare policy, when we know it's only about 10% of the difference in health between me and you. But at the same time, we're mandated to do public health services. So how we add this new layer of public policy making onto the already loaded plate, and then with shrinking budgets, is really something we haven't figured out.
Lee, what do you think?
Well, first off, I agree with Sarah that so much of this goes on without anybody even noticing. It's about like how many of you worry about whether the light is on in your refrigerator when you shut the door. You know, do you think about that? And I think, and it's unfortunate, but I think it's true, that's about how much that very basic infrastructure, which, by the way, is what has made us extend our life by decades, certainly more than the newest statin drug or the newest lookalike antihypertensive. So I agree wholeheartedly. The foundation, the bedrock, is those things that don't catch anybody's attention and you don't talk about at cocktail parties. Then secondly, I think medical care is so easy. I really do. I think being a doctor is very straightforward. It's understandable. Health policy and healthcare financing is where I think it gets really tricky. And I don't profess to know that, except to say that the way we're financing healthcare, Randall pointed this out, is still essentially the remnants of fee-for-service basis where people get paid for doing more. And I don't know if population health and looking at and funding that keeping a population of people healthy will be the new religion or the new mantra, but I think there's something in there, and I think that ultimately that's where we need to shift the financing.
Yeah, I just want to remind you, if you'd like to be part of the conversation, you've got a question, write it down. Someone will pick it up from you. Same thing. First, let me check in with our fact checker. Do we have any things with our fact checker? We doing well over there? Okay, so far, you're all doing great. Okay, good. Nick, do you have a question for us from the audience?
Yeah, we do have a question, Alan, and this question is from Sophie in Lawrence, who asks, can you discuss, LBL panelists, how advanced healthcare directives could help eliminate costs and energy towards end-of-life care?
Would
No, go ahead, Dirk.
no, I'll go here.
Okay. I touched on that a little earlier about really care within the last couple of weeks of life. You know, when people are at the end of their life, the advanced directives really help to make it very clear, because then we really, there's always discord in the family at the end of life. As much as you think that everybody's lined up and in step, there's very seldom the case. Matter of fact, as chief medical officer, I very often, probably at least a couple times a week, get involved in family meetings that because there's some kind of acrimonious, it's usually the long lost daughter-in-law from San Diego that hasn't been around for the last few years, who shows up and wants to strong arm the family and into doing something that maybe the loved one didn't want to do. The good news about advanced directives is that we get to pay attention to exclusively then to the person who is the one at the end of their life. So we don't get into this fire drill. And I think they're so critically important. And it's just very surprising to me, I must say, that I don't want to have a show of hands because it'll make many of you uncomfortable, but many people that you are very sophisticated, you think would have this ironed out, get to the end of their life at 88 years and have their cancer, metastatic cancer, something like that, and don't have anything that is an advanced directive, and then they're left to the wills of their family members, and oftentimes there's acrimony and they'll never see it, and it's an incredibly wasteful and really painful emotional time.
If I may just say, a standard line I always say is, if you have a chance, go to something called Gapminder that'll show you plotting out longevity over the last 200 years. And so that we know that in the year 1900, the average age to live here was about 48. And in North Carolina, at least about 40% of those people in 1900 would have died of infectious diseases, which is really the bedrock of public health. Walter Reed, who came from North Carolina, Virginia, was really the forerunner of public health epidemiology. He's considered to be the founder of that, more or less, which is interesting because now we have Zika. It started with mosquitoes, and now we're back to Zika. So the more things change, the more they stay the same. But the point is, when I tell people that the average lifespan has increased 30 years, I say there are two words to explain that in the 1900s: public health, clean water, vaccinations, and antibiotics. That's why 40% of people in the year 2000 don't die of infectious diseases. And then I tell people in the next 100 years, there will be two words to explain whether we're successful or not. And those words are public health. But this time, it'll be heart disease, it'll be stroke, it'll be cancer, it'll be lung disease, and it'll be unintentional injury. Those are the 5 things that affect the public's health. Now, we could wish that it was as simple as an antibiotic that helped us in the 1920s and 30s, but it's not. It's going to be more complex this time because all of those things I mentioned don't lend themselves to a shot or a pill or clean water. So we have a challenge, but I would argue that this will be the century of public health. It's just going to look different. It's going to be the prevention of lifestyle diseases, to Sarah's point, that are many times affected by the social determinants of health. I'd be interested in a fact check, but most of us would argue that 90% of your health is determined by things outside the doctor's office. I'll give you a simple statistic. I'm an obstetrician. In Missouri, we have a maternal mortality rate, mothers dying, of about 30 out of 100,000. The national average is 20. So you would come to me and say, well, Randall, you're an obstetrician. You need to be giving more heparin for pulmonary emboluses. You need to be giving more blood banks for postpartum transfusions. And no, nationally, 2/3 of those women will die from violence. They'll die from either domestic violence or suicide. So as an obstetrician, if my only goal is for a baby to have his mother a year later, I'm going to put 2/3 of my effort, not in heparin, not if I'm worried about the public health, I'm going to put it in those things Sarah's talking about, because that is what is actually killing those mothers.
Well, you've raised a point, which is one of the questions I was going to ask you. Here in Kansas City, the Mayor's Anti-Violence Task Force recently released its findings and recommendations. One of the recommendations was that violence, and particularly gun violence, be approached as a public health issue. What does it mean to treat violence as a public health issue? Most of us probably think of violence as a law enforcement issue rather than a public health issue, but given what you just said and what Sarah's been alluding to, I'd like to get everybody's reaction to that. Sarah, you want to start?
Sure. I think it's very simple. You control the spread. If violence is a disease, we have an entire division at the health department devoted to interrupting retaliatory violence specifically. So if you look at it as contagious, which we think a lot of these, I would take a little issue with the term lifestyle disease, but I get where we were going with that. If we think of it like a disease, we think my pride is threatened, my reputation is threatened, you killed someone close to me, now I'm going to go and do the same thing to someone that you love. So that's one style of violence, right? Domestic violence is another step. So we have to get to the root causes of these things, and we need to interrupt them. We need to control them. I compare it to opiates. None of us would say the only way to cure the opioid epidemic is to never have any opiates out there. Like, we don't believe that's true, right? Because we know people are going to get those things. So we know it's a multi-pronged approach, right? I'm going to treat, I'm going to interrupt, and I'm going to use data to try to predict ahead of time where there's going to be hotspots, and I'm going to put resources there. So I think we know how to treat things if we're willing to make the mental jump from violence as a law enforcement issue to violence as a public health issue, and we're willing to broaden the definition of what public health is. And I think that's at the foundation of this entire panel, which is change the definition of what you thought public health was to really understanding the root causes of this disease. And gun control, controlling the amount of guns, is the same as controlling the amount of any other thing that could be deadly if used wrong. I don't see it as any different, except we've added this whole political layer to it, which makes it very delicate to talk about, when I think we wouldn't be talking about any other dangerous thing in the hands of people who shouldn't be in in any other way. But because it's guns, we aren't allowed to say that.
Lee, what's your take on it?
If I ever get gray hair, it'll be because of this topic. I've testified twice so far in the legislature in Kansas on this exact topic. I'm sure many of you have read in the newspaper about the legislation that will go in effect July 1 that will allow for handguns, concealed carry at our hospital, the only one in Kansas City, by the way, that would allow that. It has us terribly worried. And I so much agree that we need to have these same kind of civil conversations on this topic with people that are on what I would, at least for myself, the other side of approaching gun violence as a really significant public health problem. I think of it back. I remember when my dad put in seatbelts in our car way back in the day. He actually installed seatbelts when they weren't even required yet. And, the car manufacturers did not want to put seatbelts into cars. Pharmaceutical companies did not want to put the child-proof caps on plastic bottles. And I just think that until we get to a point of having civil conversations, not about guns as a Second Amendment right, but rather a pragmatic discussion of how do we approach a public health problem, we're not going to have civil conversations that lead to any resolution.
Randall, you want to wander into these waters?
Well, again, our thoughts on this are, again, in the very beginning I said the health, safety, and well-being of all Missourians. And so, our thoughts on that are, again, to get the thought leaders on that. I do just want to parenthetically add, because I say this all the time, and I almost feel like I wouldn't be transparent if I didn't say this, is that I go all around the state saying the number one public health crisis of our time is opioids. I think about it every day. We will be coming out, I hope next week, with an incredibly comprehensive policy on opioids by the governor. It involves 5 cabinet agencies. It starts with a letter to 40,000 providers in Missouri. And so, in the traditional framework of public health, well, that's not clean water, that's not an infectious disease, that's not lead. But I'm just telling you, the people of Missouri are paying me. The one thing I think about more than anything else every day is opioids, and it affects 1 out of 4 families. And I can just, if we have hours, I'll regale you with stories about traveling around Missouri talking to people at every level, EMTs, critical access hospitals, ERs, families. So I'm hedging a little here, but to us, opioids is a huge public health crisis. So all of these things that end up in morbidity and mortality to us are public health crises.
Okay, so we often hear about a crisis of mental illness in the country, which of course relates to everything we've been talking about here today. People with mental illness are in jail or in homeless shelters rather than receiving treatment. Is this a failure of the public health system? And is it one that adequate funding might go a long way in solving? Sarah, you want to start with that?
No, just kidding. I don't see, again, how we can lay the blame or the failure to act on one system in particular or one discipline in particular. And I wouldn't say we have a mental...
I want to interrupt you just for a second.
Okay.
Willie, I understand what you're saying, and if I was inartful in the question, it was not my attempt to create that. Really, it's more the notion that sort of the whole mental health crisis that we have in this country, how does this weave into what the public health system has had trouble grasping or grappling with, and would more money be a significant impact? I mean, you think there would be a significant impact in the outcome?
Absolutely. Absolutely. This is a lot like, to me, it's a lot like, so I don't think we have a mental health crisis. I think we have a mental health treatment crisis or a failure to adequately support. There's a lot of stigma, right? So we have, just like any public health, any good public health campaign, right? There's going to be different layers to it. And there's going to be this outreach layer that talks about destigmatizing, mental health screenings. But we know what the evidence says about how to treat. There are so many things in public health that we know what to do. Just give me the money to do it, right? So I think about lead paint, for instance. which is related to mental health. So if you want to do violence prevention in the public health model, you play the long game, right? So I know that there is a correlation between our zip codes with high youth assaults, youth homicides, and our peak exposure to lead 15 years ago. They're the same kids, right? Freddie Gray, if you know Freddie Gray, Baltimore, right? He was one of the lead baby cohorts, and they were exposed to lead some 30 times, like the recommended amount. And it affects your impulse control. It's very, very salient in boys and young men. So if I want to play the long game, unfortunately, the long game is past term limits, so we don't often get a lot of investment in things you're not going to see pay off while you're still around, right? So I think about mental health, and I think, okay, let me take it back. Let me take it back to when that baby was gestating. Let me take it back to when that mom conceived. Let me take it back to when her mom conceived. And it gets very overwhelming. But we know what works. We have this amazing Kansas City Assessment and Triage Center that I think is one of very few in the country that are using evidence-based interventions. It sounds like, we don't know yet, they're still doing an assessment, but it's this alternative to jails or emergency departments. Like, it's very simple. We know there's a payoff. We know there's an ROI of investing in these things. And yet, I don't know how we get someone to have the courage to say, you know what, I'm taking money from one place and putting it in another. And on the year-to-year budgeting, and we've all probably been in those conversations, to get the needle to move slightly it takes hours and hours and hours of work from the people working for, we're trying to lobby for this budget. We're trying to say we need more money, but we're maybe going to get this much more. And maybe in 10 years we'll have shifted. But for some reason, like what we know in the research of what determines health doesn't match up with the funding. And we're going to incrementally move, and I'll be long dead by the time like the funding matches up. And I'm going to live a long time. I am in a low life expectancy zip code, but I work out every day. I also have hobbies. Let me say that in those introductions, I didn't know we got to put our hobbies. So I feel like people think I don't do anything fun, like mountain climbing or running, but I do. Ask anybody. Okay. Just going to throw that in there before I go.
I have so many questions now, Alan, I can barely carry them all. The first question then is about your hobbies, Alan. Okay, I'm moving that one. Lots of complaints about money. If the money available for public health is so terrible, if it were doubled though, how would those new funds be spent? How would you like to see those funds spent?
Randall, you want to start with that?
Well, again, I think I'm very passionate about local health departments. I think that we have a duty to help shore up these local health departments throughout Missouri that I go to. So I would put a tremendous emphasis on increasing the infrastructure. We are working with the Missouri Foundation of Health to do that. We will start in June or July now, meeting with all 115 health departments in Jeff City, either every month or every other month. That has not been done in Missouri in a long time, 10-year. Rex, how long is it? It's been a long time since they all got together and met every month or every other month. We'll reconstitute that. We're reconstituting the Board of Public Health statewide that kind of went away. So I would put money in infrastructure first to support local capabilities and resources. And then for me, I would then take the money and put it into opioids, which to me, again, is killing more people than all the other social determinants that I know of. And so that's where we will be putting our main emphasis is on opioids.
Lee?
The one thing I agree with what was just said. One thing I would like to add is that a lot of times we're not talking about, in the broadest interest of public health, not necessarily having professional people that are doctors and psychologists and nurses and those folks, but a lot of the public health problems have their roots in isolation and social distancing, so they're not really around other people. One of the things I think we need to really look at is realistically speaking, one, what has worked around the world, two, what have been demonstration projects that show us, for example, that community health workers, these might be high school diploma people that are trained with some just basic interviewing skills, ability to do home visits, that they can go, they can weigh somebody, they can sit down with them and do a pill count, talk to them about their medications. I think that one of the things we do, and Sarah talked about this, is we spend so much on the medical and professional side of the public health equation, and when in reality, there's a lot of community health worker type programs that I think can go out into communities and be very, very effective, and not necessarily be the people that have 19 more years of post-high school education.
I don't get to double my budget.
Oh, go ahead. We've already heard yours is the best
Home
in the country,
visits,
so therefore
home
you-
visits for first-time mothers. We've lost a lot of that social cohesion and capital that the village used to have, right? You had, your mom knew how to breastfeed, so she taught you how to breastfeed. Well, it doesn't fly that way anymore, right? So creating community in that way. Lead pain abatement. Super unsexy, but data, well, I mean, to most people, not to me and my team, but big data and analytics. Right now, we have some divisions within the health department that are putting data in 3 times, like the same data 3 times, like one for the feds, one for the state, one for ourselves. And none of our like FQHCs and hospitals and public health, we can't talk to each other. We can't make our data, so we can't track one person from Sam Rogers to Swope to Casey Care, unless we want to pay a lot of money for a health information exchange to do it for us, right? So we really do not have a lot of infrastructure. And I would just write people a check. So I'm a big proponent in cash. I love cash. I love income. And so one of the other panels we had before was really focused a lot on refundable earned income tax credits. So I think if we had a little money to put into public health, we know that cash transfers, a flush of cash transfer for low-income working families has huge health benefits for the kids in that household. So that's probably somewhere I would funnel a little bit.
Okay. Nick, you have something else?
The next question comes from the Sievert Coop of Kansas City, Dr. Rex Archer. Dr. Archer, would you mind standing for us? Thank you very much.
So, when I first wrote this question, you've already touched on some of it, but the 35 nations that are part of the Organization for Economic Cooperation and Development, we're the only one that spends more on illness care than we do on other social services. And you started to touch on what are those other social services, how do we redirect to some of these other things. The living wage issue is an example, could probably do more. And then the kind of the last question is, as we think about this last century, don't forget women's right to vote, FDA, EPA, OSHA, all these changes that occurred that have changed the structure that are protecting people's health.
Okay.
Thank you.
Brad, anything you want to comment on that?
Well, again, I just think that, Rex and I have talked, and I'll just add that, one of the wonderful things is that we have in Kansas City literally what I call the art of the possible. I mean, if you look at what they're doing, it is so much more than what some people would define as traditional public health. They've done a phenomenal job of engaging the community, as has been pointed out, both resource-wise and organizationally. They have a certain amount of independence that is very helpful in some very contentious issues. But, I just today reviewed one more time all the different things they're doing, and you just have to kind of sit back and applaud. So if you wanted to know what a vision for public health in Missouri would look like, you would just spend some time in Kansas City, realizing, of course, that DeKalb County and Shannon County and some other counties are never going to have those kind of resources, but at least it gives you kind of a prototype in all the areas that they are involved in of where we kind of want to go.
Okay, let me just ask another question here. I think we know that basically obesity, childhood obesity and diabetes are very large cost drivers in our health system. That much we know. Do you see it as the role of the public health system to coordinate with other parts of, in other words, there are other entities within our government, the education system and others. What, you actively work with them in order to sort of focus on some of these issues, or are we kind of siloed in that regard?
I'm going to defer to Sarah in a second, but I think, you know, what Sarah and I would agree on is that we have to shift from spending all that money on treatment and moving it into those social determinants of health, whether it's making cities more walkable, increasing better nutrition in all our communities, that is a huge part of public health is education. I mean, that is what's killing people. It is chronic disease. It's heart disease. It is diabetes. And so you're not going to solve that with a vaccine. You're going to have to address those with prevention and education. And I think Sarah would take that a step further. I don't want to put words in her mouth, and build it into your communities.
Mm-hmm. Yeah, I think an obese child is the product of a very, very broken system, and we're not going to cooking class our way out of it. Like, you're not, that this is much deeper than that. This is food deserts and policy and preschool and sidewalks, and this is a lot of things on top of each other. And then at the base of it, this system incentivizes bad eating, because the cheaper stuff, I mean, if you need calorie dense foods and you only have a certain amount of money to spend, everyone in this room knows, like, you will spend your money rationally. I think people are very rational. I don't think they need to be overregulated. I don't think I need to restrict what you can buy on your SNAP benefits. I don't need to blame the victim. I don't need to soda tax you. I just need to create an environment that makes it easy for you to eat well, right? So we look at programs like Double Up Food Bucks, right? Which is like a rational economic incentive, which is, if I could get twice as much money at the farmer's market with my SNAP benefits, why wouldn't I? Those are the kind of like really innovative things that are happening in this city and beyond that I think are really going to change. We've had more information thrown at us about what's in our food in the last 30 years, and we're only getting bigger and sicker, right? Calorie labels, it's true. Like, you look at the evidence behind whether calorie labels work on, say, the movie theater. Have you ever been in line at the movie theater and you're like, this happened to me, I was squinting because I couldn't see. I was like, oh, the nachos, only 350 calories. And this woman in front of me turns around, she's like, it's 1350. And she just looked at me like totally disgusted. But maybe for me, like, I'm on the margin, right? So I'm like, oh God, no, I'm not getting those nachos. But that's because, like, I was thinking about that rationally, and I'm also the type of person who's going to be moved. So unless public health really becomes embedded in behavioral economics, starts creating systems that are going to make people make the right choices, we're not going to get where we need to go. We all remember the health class videos, right? Like, you remember the health class videos about STDs, or Benny and the roids, that's my favorite one, right? I'm gonna go out on a limb, and you can fact check me. Tell me a story of someone seeing those videos and being like, you know what? I'm not gonna do drugs. Like, we know it doesn't work. We're still funding the DARE program, right? Like, like the evidence, RAND studies, Pew Charitable Trust studies are saying, like, that stuff doesn't work, and yet we're still doing it, right? And that's the history of our field, and we need to honor it, but we need to help people move to what is actually going to change behavior.
Okay. Lee, you want to jump into this for a minute?
So you watched the videos and just knew how to do drugs better?
Yeah. I was like, that looks fun.
See, you can learn as an adult.
Cool.
I mean, that's possible. This is probably the most discouraging. Well, we've had a number of discouraging topics. Thank you, Alan. But this one, the one on obesity, to me, and I see it in hospitals, of course, there's not a day that we don't have somebody that's 500, 600, 700, 800, 900 pounds, or all those at the same time. It's very discouraging, and yet they're in a hospital. Whatever we do is going to be patching them up, and then something will happen. But I feel like when we do that, there's a bucket of water. I'm in there moving my hand around, making ripples, and then when I take my hand out of the water, how long does it take for the ripples to go back to normal? And I'd like to say that I have more optimism than that about this, but I think we still have to try. And I think where we have to try, And I think the things that I've learned as a family physician and as a hospital guy is I think people can learn behavioral ways to adjust. I joined the Army when I was in the Air Force for a long time, got out, and I joined the Army at the age of 61, an unusual career move. But and I had to lose a few pounds, so I sat down with a nutritionist to walk me through what is it going to take me to lose 15 pounds, and something as simple. And I was a motivated adult learner with the capacity to learn, granted, I think, and go through something as simple as portion sizes. And I'm supposed to know this stuff. Go through portion sizes and nutrition labels, and I learned that anything with greater than 5 grams of sugar per serving is something that I just don't eat anymore. And I lost a pound a week for 20 weeks, and it has remained gone. So I think it can be done, but I think we have to be very focused on behaviors, because I don't think the rah-rah, and I gave up the pom-poms a long time ago.
But I just want to piggyback. I'm sorry, Randall. There's something special about you that you were able to do that, right? So there's something inside you that had agency. Like, you knew if you tried to do something, you could do it, right? Which is something I take for granted, that I can go to the gym and I know I'm going to work out and I have control over my life. And I think that one of the biggest public health risks is hopelessness and a lack of control over one's own life. So when we talk to these kids, 13, 14 years old, and they're like, I'm only living to be 23, maybe, and they really feel as if they don't have any control over their own life. Talking to families whose kids, like, I told this story to my class, I feel like last week, it was like the kids duck under the window. Like, every time they walk across where you would put a Christmas tree, they just instinctively know to crawl under the window because the bullets might come in. Like, so if I'm teaching you about portion sizes versus someone who's been exposed to that trauma and those ACEs, right, the adverse childhood experiences their whole lives, we know through scans of their brains that it's more difficult to make rational decisions if you've been exposed to trauma your whole life. And so that's where I get just really overwhelmed. That's where I get really discouraged, is I'm thinking, how am I going to undo all of this in addition to preventing it from happening later, you know?
Well, when I first met the governor, we talked about this, and so we're going to launch a program that we did in North Carolina where down in Cape West Plains at Ozark, they're doing it, and when I was in St. Louis, they were also doing a part of it. But it's promoting 5Ks on the weekend, trying to get people who normally wouldn't run them to get out and walk them or run them. The idea being that it's money for a good cause. It's usually for MS or breast cancer or some local thing. So we think that part of it is important, that you're being other-centered, which is a value that the governor, I think, is very important. The second is we think it promotes community engagement. People bring their dogs and their strollers. There's a young girl on our website named Piper, a little baby that was being strolled down in Poplar Bluff when I ran one. So I run one about every weekend. I'll be back here in Kansas City next Saturday running the one for heart disease. I'll be back here in Kansas City running the marathon in last weekend of October, I think. So we're trying to model that behavior, and the governor does it as well. He ran last week, I think it was. And so we're trying to model this behavior of getting out and exercise to raise money for good causes and to get out. And down in West Plains, they call it couch to 5K, I think. So we're not trying to appeal to the people who are out there trying to run, 19-minute 5Ks. We're really trying to appeal to those people who wouldn't do it on their own, but if it's for a good cause and, people are doing it, maybe they'll get out and do that.
Okay, I want to sort of follow up on something you said earlier. We've heard a lot of this conversation, you're talking about a lot of things that and you all agree in many ways of things that need to be done if you're really going to tackle the root, if you will, of what leads to the result that no one's satisfied with. And you've said that the governor wants to pull together the best minds. Mm-hmm. Well, my question to you would be, don't we really know pretty much what needs to be done? And if we acknowledge that their resources are what they are, in other words, there aren't going to be any more resources, do we really need to spend a whole lot of time reinventing the wheel, or do we just sort of are we willing to kind of tackle what we know will work?
Now, I just respectfully disagree with the premise. If we go over to any hospital in Kansas City right now and have a procedure, how will I be billed? What will the bill look like? I'll get a bill for the anesthesiologist. I'll get a bill for the arthroscopy. I'll get a bill for the lab service. I'll get a bill. I'll get an $80,000 bill itemized by all the things that were done to me. That's where the 19% of the gross national product is going. So we have to transition that money. That's the heavy lift to prevention to affect these social determinants of health. And that hasn't been done yet. So when you say we know what to do, well, yes, we know what to do. Now we have a very heavy lift of working with Lee and others, some really bright people, and say, help us do this.
Is it a question of political will?
No, I don't think so. I mean, I think when I talk to Herb, and I literally have talked to every healthcare system, and they all agree with me. And Lee, I think, would agree with you. I mean, these are really bright people who realize that our society cannot sustain increasing the GMP to 22% on the route we're going. And I give them all the credit in the world. I think they understand that. And so that's what we'll be doing is the Medicaid block grant comes back in a capitated fashion, the $10 billion to Missouri, and that's what you're going to see happening is to sit down with people like Lee who have to live with the decisions and see, Lee, help us with this. You've been doing this how long? 35 years? You know, I'm not going to tell you because you know infinitely more than me how to do it. But how do we get there?
Was that a question?
If you can solve that in about 30 minutes, that'd be great.
You know, here, I absolutely agree. And I think that really, just imagine a bold experiment if we said, again, to population health, and said, we're going to give a block of money to take care of this group of patients, and you, healthcare system, working within that, decide what is best. Will we do as many hip and knee replacements, or will we channel people to physical therapy, weight reduction, mobility, yoga, and the like? I damn well bet you we'll do a lot of that if the profit motive is taken out of that. And we haven't even scratched the surface on that. Innovation in healthcare is not our strong suit. I mean, yes, you read about all the whiz-bang things, and yet that the health system innovation that spins off money for public health and prevention, we've not even scratched the surface on yet.
Nick?
Yeah, we actually have a fact check, Alan, and it's from the UMKC catering services. They said there was 4.95 grams of sugar in the chocolate mousse. So Lee, you're actually fine, Dr. Norman. You managed to hit your diet recommendations there when you ate that dessert a little earlier. A lot of questions actually for Dr. Williams, if I could be so bold.
Yeah.
Do you really believe block grants will really be more beneficial to needy citizens of Missouri? What happens if the funds run out?
Yeah, there's a lot of angst about that, and I certainly appreciate that because it is a finite amount of money. And so, again, I am encouraged and optimistic that based on the people I've met in Missouri, if you give them the challenge of transitioning from a procedure base, the more you do, especially the more you operate, the more money you make, and say, look, this is our budget. Help us get to where we need to be. I've just been incredibly encouraged by the leaders of the systems here that they're just really bright people. They're very talented. I think giving them local control that they can do it. And that is our North Star. From the very get-go, I have lived through this twice before where other people told me, I know more than you, you're just a doctor, you take care of patients, trust me, we know better, we're really smart, we've got these data, and both of them have failed. I mean, in 1995, my practice got bought, I got millions of dollars, they told me they're gonna pay me my same salary. I said, how does that make sense? Because I own my own practice. At the end of the year, whatever's left, I keep, So I really try to save money. And they go, well, you don't understand economies of scale. You don't understand competitive pricing. I said, well, I guess I don't. 6 years later, after they lost $40 million, they begged me to leave. I was like a football coach who'd lost 50 games. It was like, please, go. And so our North Star in this effort is to give the Lees of the world the chance to do it in a way that the people who have to live with it. You know, one side effect of all this is that 50% of all the doctors in the United States are burnt out. They are unhappy. Nobody ever wants to talk about that we've created a system in which 50% of the providers, that was not true 10 years ago when I practiced. And I always tell people, do you really want your pilot of your 747 to be miserable, sorry, Bridget, and not unhappy and not liking what he does? I don't. I like him to feel pretty good about things. So that our North Star, our commitment is that in this iteration, that we want the leaders, the people who have to live with the decisions. I mean, the private practice I left, my one partner paid a scribe $40,000 a year just to walk around recording things. How does that make sense? How does that help in more efficient health care? It doesn't.
Okay, so Lee, if you're going to get control of all this stuff, you think they'll also let you keep the guns out of the hospital?
Not in Kansas.
Do you think that, I mean, you agree with
Yeah, I do. And, you know, I think one of the problems from a health policy, and I'm no health policy expert, but I do think that we've tried to make these huge programs that are of immense kind of size and complexity, when in reality, I really think we need to do more experimentation, as what you describe. And what you have talked about too, Sarah, with how do we build out the continuum within a finite population over a period of time? I realize people are mobile, but I think we have to experiment and not necessarily feel we have to have a thunderclap, a cataclysmic change all of a sudden, and then we have a new health policy that affects every man, woman, and child in our country. Because I don't think we haven't seen it. I remember doing this in 1991 when the Clintons took the first whack at the healthcare plan then, and as you pointed out, Randall, the people closest to it, the caregivers, were not even at the table. It was policy wonks behind dark curtains someplace. And I think that we've been so much trying to do it all in one fell swoop, and I think we should experiment a little bit and try it in smaller ways.
In fact, and I think back to the mental health question, I think, and for the students over there, I think that one of the great skill sets you need in public policy is to be humble. Humility is a great virtue in what we do. We look at the opioid crisis. That was not an EF5 tornado. That is iatrogenic. We created that, okay? I was just overseas in Iraq. Doctors in India, the UK, Sweden, Lebanon, Egypt, and where else, they don't ever use opioids for post-op pain, ever. They looked at me like I had said, take arsenic. And yet we created that. And read Dreamland by Sam Kianonis, who was here at the Missouri Medical Association in Kansas City a month ago with Senator Schaaf and me. You'll understand that people with good intentions can create systems. In North Carolina, when we deinstitutionalized mental health, about a third of many ER beds on any given day are filled with involuntary commitments because somebody said we think it's right to deinstitutionalize mental health. We're not going to replace it with anything. We're just going to shut down the hospitals. And so now all those patients end up in ERs. And Lee, I'd be surprised if you don't have right now in your ER, 20 or 30 people who have nowhere else to go. The sheriff brought them there and said, here. And so there they are.
Well, Sarah, you are the health policy wonk up here, so do you want to sort of weigh in on this? In terms of, do you think that giving that money back to the states for experimentation would make it easier or harder for you to do what you do, or do you think it would have no effect?
I love experimentation. Let me give you an example. So it's very minor compared to what we're talking about nationally. Who knows how that's going to turn out? I just close my eyes and hope for the best, honestly. Just focus on Kansas City. So we have a health levy. You know, it's your property. So if you're a property owner in Kansas City, Missouri, thank you very much for paying into the health levy. And for a long time, so we have a portion of it that goes to indigent care, and I don't love that term, but it just basically means uninsured, low-income Kansas City residents. And so that money goes to our FQHCs and our Truman, right? So, but it also, for a long time, has gone to Children's Mercy. And Children's Mercy, thankfully, does not have a ton of uninsured kids, because kids are often better taken care of than single adults in the public system. So it's a little bit inefficient to spend money on health care, indigent health care for kids. So this year, for the first time, we have successfully transitioned that contract to, instead of paying for clinical care, we said, tell us what you want to spend it on. Here are some ideas. Here is some basic rubric, right? It's got to be Kansas City residents. We prefer it in our low life expectancy zip codes. It really has to get at root causes. And it's got to align with the city's strategic plan for health, which is called the CHIP. 4 of the 5 issues are social factors. So extra points if you're kind of focused on one of those things. So this month, the Health Commission, which is a mayoral appointed body, will be reviewing those project proposals. And for the first time ever, we will be spending health levy money in a clinical care setting on social determinants projects. We are so excited about this. I mean, granted, it's like barely over $500,000. It's not soccer stadium money, right? Like, this is like very little bit of money. But if we can show really great progress on innovative projects for public health, imagine what that's going to do. Now, that's different than Truman, who, like, it's hard to keep the lights on at Truman, right? Like, that is a public hospital. You get great care there. I've been there, right? Emergency department. Anyone with kids has been to the emergency department at Truman at some point in their life, right? Like, they are doing great things, but they're under completely different circumstances than a Children's Mercy or an FQHC. And their day-to-day cash on hand is going to be very different. So we have to treat them differently. But what if we could start just shaving off a little bit at a time for these projects that are going to hit our social determinants? That is really, really exciting to me.
Nick, you have another question for
Yeah,
us?
let me ask very quickly. FQHC is repeatedly mentioned, and FQHC stands for
A federally qualified health center.
Federally Qualified Health Center. Here's a question for you. Don't most countries that provide better public health and prevention have single-payer systems?
Sounds like a fact checker question.
Lee, you want to start with that one?
You know, I don't know the answer to that. Most is I think many do. I think that a lot of the countries, I spent a fair amount of time in Croatia, for example, after the 92 to 97 war there. And one of the things that they did was they said, we're going to have a single payer system, but they also made it so that people could buy up for kind of higher end care. But I'll tell you, the Chevrolet, the stripped down Chevrolet, that's not my moniker, that was the term that was used there to describe their single-payer system, worked beautifully. And that was in a brand new country, war-torn, and a year later to have a stripped-down Chevrolet single-payer. My gut feeling, Nick, or whoever asked the question, is I think that would lend a tremendous amount of support to these goals that we're talking about, because I think when we integrate people in at earlier points, not at end stage of disease, but earlier on and into primary care, I think it helps. That's still not public health, though. It's just an earlier access to medical care.
Yeah.
So,
I mean, I was in Libya after the revolution, helping them organize their healthcare system. And about 40 countries kind of pitched, because Libya at that time had a lot of money because it's an oil-rich country, about 8 million people, but it quickly destabilized, and that's not the case now. But we kind of likened it to Survivor, where 40 countries pitched their healthcare system, and we didn't make it past round 1. They liked our technology, but didn't like the fact that we spent 18% of our GNP on healthcare. So they went more with Singapore and some other kind of models. I work with a team from the UK when I'm overseas, and so I spend a lot of long nights because there's not a lot to do in Baghdad after 5 o'clock. Talking about the UK system, which is single payer, they're pretty, frustrated with that. So I, for people who see that as kind of a holy grail, I'd encourage you to spend time talking to people in the UK. Again, I will tell you, the rest of the world looks to the United States as the model for healthcare technology, for science, for state-of-the-art practices, things like that. So to me, if you have that kind of brain power that's able to do that, why not, to Lee's point, unleash that brain power locally to try to figure out the financing part of it?
Nick, you have another question.
Yeah, first of all, I can't tell you how good the UK health system is, but I am a product of it, and I'm only 93. This is a serious question, though. All right. And this is a very topical one, because if you saw the stories in the Star over the weekend, this is back to the issue of mental health, and you saw a front-page story about people being now warehoused in Missouri who have mental illnesses, if you saw that story, and now put into nursing homes. What better alternatives, says the questioner, can be implemented to replace, in their words, warehousing mentally ill persons in nursing homes where they are heavily medicated but only lightly treated?
Randall, you want to start with that?
Yeah, I can, certainly. Well, the first thing we think is that the head is connected to the body, that this artificial distinction between mental or behavioral health and physical health is one that we need to diminish that thought. I come from a super agency in North Carolina where we ran everything, a $20 billion department, 5 of us ran it. So every day I met 7 times a day with the head of mental health, physical, with social services, public health. So we always approach patients holistically. That's not the case here in Missouri. It's very siloed. So we are moving very rapidly to a more integrated system. So that's my first point. Second point would be is that we have to get more providers and more treatment facilities. There's just no doubt about it. And that's a nationwide problem. That's not confined to Missouri. I'd love for you to fact check this for me because I've been looking for it. I think we have 456 psychiatrists in all of Missouri, the whole state. But I've been looking to I asked somebody the other day if they'd make sure that's correct. So if you can let me know, that'd be great. So we think the answer there is that you have to spread out the number of people treating. So getting back to the governor's second biggest priority in healthcare, which is workforce in rural and underserved areas, is that we need more GPs, family practitioners, internists comfortable treating behavioral health and mental health at the point of contact. We can't have everybody drive to Kansas City and St. Louis. We need more local providers. We need to really expand our clinical psychologists and social workers. So it's a heavy, heavy lift. There's just no doubt about it, but we think it is a huge issue.
Sarah, given what you're talking about, taking this mental health issue to one step further, clearly this sort of fits right into that whole group of problems you talked about in terms of social determinants and all how children grow up, neighborhoods, violence, all those kinds of things. What is the public health department here? What are you trying to do to deal with that within the context of trying to sort of, this sort of whole community aspect of things?
I think it's less about what the health department itself is doing versus what the community has said they prioritize. So we used to ask, when we were doing our health improvement plan, our strategic plan for health at the city level, we used to ask, which one of these diseases do you have, right? It was very disease-centric. Instead, flipping it to, tell me what you love about your life. Tell me what you would change about your neighborhood, right? And out of that came very different things. And one of the things related to this was the need for culturally competent, and I hate that term. There's nothing I hate more than that term, but I'm using it because it's a very fashionable term. Mental health. So, and that goes across all clinical care, but specifically mental health. In our community, folks were saying, we went to 24 neighborhood association meetings. We went to churches, we went to schools. We said, tell us what's going on. And they said, I feel like my doctor thinks I'm an idiot. I feel like I don't have a therapist who truly understands what's going on in my home life. There's no mid-level, there's very few mid-level practitioners when it comes to behavioral health, and that goes back to, I'm on the board of Healing Arts, so I'm not speaking for them, but there's a lot of discussion on collaborative practice and like who gets to do what and who gets to prescribe what, and there's a lot of that conversation going on that gets away from, the point is to get people treatment. We are a mental health provider shortage area in this region. We don't have a wraparound service, right? Like I would say the closest we come in the health department would probably be Frank Thompson in the front, and he's over HIV services. And I think that our Ryan White grantees with persons living with HIV are very good at thinking about mental health, case management, housing, and understanding that you have to treat the whole person. But if it starts with this understanding that everyone who gets health levy money has to report to us, because we manage the contracts, what did you do this year to train your providers in cultural humility, cultural competence, right? Really understanding. And how are we going to workforce develop folks from communities to become physicians and to become psychiatrists and to lower the barriers to getting into school? I think that's where we start to see a difference. But really, I mean, the city has already said, we believe in this. Now let's figure out how we're gonna get there.
Just for the record, my medical license is before the Missouri Board of Arts and Healing, so I agree with everything Sarah said tonight, no matter what she said.
That means my signature is going to be on it.
Yeah.
You get it. Yeah.
So I just want to clear that up.
Lee, the mental health issue.
Yeah, just a couple comments to add to these great comments already. One is that when we look at all the patients that come to the emergency department at the University of Kansas Hospital, the number one diagnostic cluster is our mental health diagnoses. And you always think it's gunshots, it's motor vehicle accidents, it's fall down, break arm, pneumonias, and the number one cluster is mental health diagnoses. So I think that gives you an idea. Number two, a very important study by the Agency for Healthcare Policy and Research some years back asked the question, what is most missing from the healthcare that you receive in your community? And it was coast to coast, border to border, in a lot of towns, this question was asked. And the answer almost across the board was, I'm isolated and I don't have communication or contact with people with similar life experiences. And I use that to tee up my comment about mental health. What I see, of course, we see patients in hospitals and difficult placing them back into settings that work for them, not necessarily skilled nursing, as Nick points out, but group homes and smaller, more flexible places where people get to interact with them more closely and without isolation in more normal settings. They're not very expensive. And I can tell you, I bet you one hospitalization with one of these mentally ill people who had some kind of bad outcome would pay for the operating expenses for one of these things for a year. Granted, that means you have to figure out how to do the financing, because you just can't take money out of this pot and go put together a group home for mentally ill. But that would be a dramatic success. People in smaller settings with like kind of backgrounds or problems do much better.
Nick, I am right here. I was talking to our fact checker here, actually. It was about the number of psychiatrists in the state of Missouri. And we're giving you a boy, because you said it was like 472?
Something like that.
We were looking at it was 468. So you were very darn close there.
Seriously.
So excellent job on your facts, sir.
Well,
No
no, thanks for
civility
checking.
bells being rung on you. But we do have a question. To what degree, if any, do you see racism as a public health department issue?
Yes.
Go ahead, Sarah.
I'm great at dinner parties because I like to talk about racism. It's part of why I moved here. So I moved here from the Bay Area of California. I'm a native Californian, and I came to Kansas City to interview here at UMKC for a tenure track position, and they were driving me down. I said, take me to your dividing line. And I was like, what? I was like, show me where white people stop and black people start. And because I knew every city had one, right? So I worked for Alameda County Public Health while I was getting my PhD. And, Oakland had the same thing, right? Oakland had that line, multiple lines that separated groups from each other. I want to talk about racism inside public health too, because I think any public institution has class and race issues within, and I think that goes for hospitals, I think it goes for the government, I think it goes for private sector, that until we are real about frontline versus management, we're looking at, tenure, pay equity. We look at, is public health doing a good job with our LGBTQ folks? Like, I'm not sure whether we're doing a good job there. So you have race and you have sex and gender and class and all these things on top of each other. I think that is the role of public health right now. I think the role of public health is to show up to a meeting on city planning, to show up to a meeting on tax incentives and say, have you thought about racial equity? Like, how is this going to affect racial equity? How does this affect segregation? How does this affect political power? And be that person, always. And so that's like what I think public health is, and I think racism. In a city such as Kansas City, you can't talk about Kansas City without talking about race. And we dance around it a lot. But we are one of the most segregated cities, and you can fact check, but it really depends on the denominator, right? So we're either 17th out of 180 or 37th out of all the cities in the country or whatever. We're nearly as segregated as South Africa under apartheid. My students and I just looked at a dot map of, not these students, some of these students, different students, of Cape Town, South Africa, and then a dot map of Kansas City, where like every dot is a household's race. And it's striking, the similarities. And so until political power and monetary power is equal among races, race is going to continue to be an issue.
Let me just sort of say that you are the third person during this year of our programs that's made the exact statement about what a segregated community that we have here. And I think many of us who've come here in recent years have made that observation more than once.
Mm-hmm. Well, it certainly, it affects us with our Office of Minority Health and disparities. I'm an obstetrician, so it's only natural that I spend a tremendous amount of time down in the Boot Hill, where among African Americans we have almost a 3 times higher infant mortality rate. So it is something that, again, that we are fully intended to put the resources of the state of Missouri to change that. And the first thing we've got to do, we have 3 obstetricians down there, one doing 500 deliveries a year, can't get a partner. Average obstetrician does 150 a year. And so we are focused on that like a laser beam. And there would be other instances, but the one that is glaring that more or less consumes me is that statistic of the difference in infant mortality in that region of the state.
Lee?
I really have nothing to add. These guys have done a terrific expose, except to point out that I lived in Seattle for 20 years and practiced downtown, and north of North 85th Street was only Canadians. Beyond.
I'm sorry. Alan, our Ambassador KATZ, I'm sorry. We worked in the same office for a little while. Alan, we had our welcome to the university party together. It was great. I would start with changing the name of the Office of Minority Health. I think, and I know that sounds a little bit trite, but I think you're seeing it across the country in that what would you like to be called? So, often we go into groups of, and this is cultural competence, right? It's like, if I have someone who has like dark brown skin, would you like to be called person of color? Do you like the term minority? How do you feel? And we did a lot of research in Oakland, and people really do not like the term minority, especially in California, where we see, my hometown is 65% Hispanic origin. So, would you like to be called Hispanic, Latino, Mexican, Dominican? What would you like to be called? And I think we're seeing people move away. And for a state such as Missouri to be one that said, hey, look, we're going to rebrand, like we're going to I think that actually would move us in the right direction. We specifically use the term inequities versus disparities. Like, there's a lot of things that local health departments are thinking about that just hasn't kind of trickled up to state health department, that I would love to continue that conversation.
Yeah, that'd be great.
Nick, you have another question for us?
We certainly do. We're going to head back to the area of drugs right now. Some people like to be anonymous with their questions, others like to be able to ask them themselves. John Patterson, where are you? John, come on, that's great. You had a question for us because you were talking earlier about the DARE program, remember that?
Yes. Okay, speaking of the DARE program, if it's well known that it doesn't work, why do we still fund it and why do we still teach our children? Do you think the DARE program should be removed? If so, how do you expect the children to learn the danger of drugs? If it teaches a few children, is it still worth it?
Excellent, thank you very much.
Thank you for your question. How old are you?
I'm 15.
Where do you go to school?
Lincoln College Preparatory Academy.
Okay, so I'm going to answer this carefully because both of my kids their applications are in for that school. So we'll see.
Now you know how I feel with the Missouri Board of Arts and Healing.
Yeah, and their dad's a cop, so that helps. So I think there's a lot of evidence that DARE is not effective. That actually there is some evidence to say that kids who go through DARE are more likely to use drugs than kids who don't. Now that's if your outcome is drugs. If your outcome is police relations with the community, I believe that is a public health issue. We know, and we're working now with the mayor's office and Turn the Page KC on a school suspension summit because we think gender and race inequities in school discipline, in preschool, first grade, kindergarten, all of those early grades is a public health issue because it's a criminal justice issue. If we can talk about community policing and those relationships, I think there are better ways to spend our money. We know that community health workers, social workers, maybe adding more training in trauma-informed care for police, like in the academy, implicit bias training. There are things I think we could spend the money on that actually would go further in like youth development than the DARE program specifically. Police Activities League. So there's like randomized controlled trials of Police Activities League, and that was found to be way more effective than the DARE program in preventing risky behaviors across the board. Because like DARE doesn't talk about sex, right? Like DARE, at least back when I took it, like did not talk about that. Actually, very few people are talking about that in schools. So if we have something like a comprehensive program like PAL, like Police Activities League, or something where we build relationships are key, not educate, scare you away from ever doing drugs. I want you to be smart enough to make the right decision, and if you make the bad decision, know you have someone you can trust that you can turn to if you're in trouble, and I think that's probably the key.
Okay, and you mentioned earlier, we talked about these campaigns that seem not to work so much. I think we would be remiss not pointing out that one worked very well, which was the anti-smoking campaign in this country, which clearly changed the percentage of people that smoke cigarettes.
But the campaign is multifaceted. The campaign is laws. The campaign is you can't smoke in here. Like no one's lighting up. This isn't Mad Men, right? There's a law that happened, right? That's public health. Public health is laws. Like that's my degree's in public policy. Like I do not have a PhD in public health, right? It's just about how do we get good policies passed. So we got good policies passed, and then there was a social stigma. So most of the commercials you see, the PSAs on smoking, are funded by tobacco companies. So I don't really usually trust those campaigns anyway. But I would say that if Frank lit up a cigarette right now, here in the front row, we would all turn to him like, gross, Frank, you can't do that. Even if there was no law, the social stigma around things leads people to change behaviors, because I don't want our relationship to be damaged. So we can't downplay the role of like, you just can't do that. Like you can't smoke here. And what got that was secondhand smoke, right? Was like, now what I'm doing is affecting you, and now I'm upset, right? And so I think that's where we need to take that success and transfer it to other public health crises.
Okay, yeah. Okay, we have time for one more question here. Nick, you have one more, or you want me to take it?
We can go to Marty in Overland Park, who is also raring to go with a question for us. Marty, your question for our panel.
At the risk of testing the limits of civility, allow
get those bells ready. Go ahead.
Allow me to encourage discussion of the following statement. The fundamental obstacle to our current health care system is the assumption that health and health care are rights.
It's very simple.
Well, Anybody want to tackle that first?
It's a policy question.
Is it? It's like a moral question.
Go ahead, Dave.
I don't know how to answer that question. I wrestle with it. I think about it. I do think that we have enough resources if it is defined as a right, that I think we can do a much better job than we do now. I don't know that it's a right, though, to be real honest with you. I'd like to believe that we could afford it were it to be that.
This is very civil. It's a right. It's a right. You're born into, I look at the wealth in this country. There's like rich kids of Instagram. You've seen it, right? Like, you've seen these kids, like, they own yachts at 16. And the fact that we are still having these discussions, to me, is very simple. The very Robert Wood Johnson, like, your zip code shouldn't determine your life expectancy. Everyone has the right to the same odds. Now, what you do with those odds, that's on you. I'm not gonna expect you to do what I want you to do all the time. But I know that, like, every baby born is born innocent, right? So at some point, like, we messed up and the system messed up. So if the odds were equal and you do with it what you will, then I would say I would be okay, right? I'd probably find another career, go pursue my hobbies, all my hobbies. But for now it's not, and I think that's why we keep doing what we do.
Yeah, it's my goal. I travel in other parts of the world. I do it here. The word right, I don't know what that means, but certainly my goal as a physician who's been doing this a long time is for everybody that I can possibly on this planet help to get access to health care and improve their health.
Please go ahead.
Let me give you an example of things I wrestle with. We had a guy that was my age, 60-ish. He owned a trucking firm and was very, very successful. He chose not to buy insurance. He had seven-figured amounts of money, that we know this, that it was all in other people's names. He had an automobile accident, came into our hospital with a head injury, and was in our hospital 300 days because he didn't meet the qualifications for Medicaid. He had enough resources that had we gone after it as a billing institution, and we see that fairly commonly, where people can make the right choices, they have the resources to make the right choices, and deliberately choose to shuttle that off on everybody else. I'm not sure that that's a right that they have. We ate the bill for 300 days. I don't know how many seven-figure dollars that is, a severely brain injured man, but that's not right. I try not to be angry about that, but it's just not fair. And those are the kind of examples that really test. And I was a social worker before I went to be a family doctor, and yet those things really test my emotions.
Okay, so I would like to ask each of you a question, maybe see if you can give me a yes or no answer, so trying to pull together some of the threads of what we talked about tonight. Is it fair to say that you all would agree that we are dedicating enough resources to healthcare and all of its attendant causes in this country, if we could somehow change the incentive system and the allocation to get to some of these problems earlier, that we could make huge progress?
Yes.
Yes.
Yep.
Okay, well, I want to thank our panel very much. I want to thank our roving reporter who at the event we had a week ago with Matthew Dow was given an official ambassador title, but since he wasn't wearing his ambassador medal tonight, we have taken that away from him. That's Nick Haynes. Thank you very much, Nick. I want to thank our sponsors tonight, the Healthcare Foundation of Greater Kansas City and Stroke Health Services. And if we didn't get to your fact check or your question tonight, if you follow American Public Square on Facebook, you will see and follow up post. They will be posted with an answer. And we now have some people we want to recognize, if I can turn the page.
Can I make one announcement real quick?
Of course.
We are very serious about being available, so I always give my cell phone number. So for those inclined to write it down, it's 919-413-7791. That's the same cell phone. I only have one, so whether you're the governor or you, that's how you would call me. And we also have opportunities now. We're creating to shadow people in the division. You can come shadow me for a day. So for the students. If you want to kind of see what it's like to do what we do, we're more than happy to do that. Again, it's just one of our fundamental values that we feel like we should be accountable. So again, it's 919-413-7791, and you're welcome to call me. Just if you call me between 9 and 3, that's when I sleep. I'll wake up and ask you how far apart your contractions are. So if you wait, thank you.
And as a return to Missouri, I want to welcome you to Missouri. Thank you very much. I want to thank our volunteers tonight for their help and the American Public Square staff. As usual, their hard work that made everything happen. 5 of your playbills have on the back page a star. If you have a star, we have a prize for you. Please stop at the registration table on the way out to collect your prize. We have some people we want to recognize tonight. Scott Curtis, our fact checker. We have a civility bell for you. We want to thank you for helping with our fact checking this season. Jennifer Sykes, is Jennifer here tonight? She's not here. Well, we want to thank her for all our help and support this season. She's been great. Vin Van Klinken, we have a Bell Ringer of the Year award for Vin. You were not at our event last Monday, so we wanted to make sure that you received that. We now present tonight's panelists. And Michelle Keller of Swope Health Services with an engraved civility bell, and each panelist with a membership in American Public Square.
Oh, thank you. That's
Now,
great.
I want
Thank
to
you.
thank everyone for coming out tonight.
That's great. Thank you very much.